All right, so just get up and a little stretch, and we're going to move in part 2 of this. This is a shorter part, but I think it's important. We talk about appearance of several common soft tissues in the human body and understand common ultrasound syntax or nomenclature. When we talk about units of ultrasound, we talk about echogenicity. And echogenicity is always relative. When I ask you how cold it is, it's freezing outside, but relative to a colder place, it's not so bad. Relative to Florida, it's extremely cold. So it's a relative marker of how bright or how dark a particular structure is. We're looking at 4 images in a phantom in front of us: a structure, a soft tissue that's hyperechoic, a soft tissue that's hypoechoic, a soft tissue that's anechoic, and a soft tissue that's isoechoic. When we look at that echogenic or hyperechoic soft tissue, there's 90% reflection of these sound waves back to the transducer. And you can actually see loss of beam with this darkening just deep to it. This is called hyperechoic. When you look at hypoechoic structures, you'll see that they're relatively dark. There's some penetration or transmission of sound waves through this structure, giving you its actual morphology. When you look at the third one, the anechoic, these are typically cysts or fluid-filled areas that nearly transmit all of the sound waves. They tend to appear complete dark black. They have a well-defined wall, and you can see this artifact of through transmission. It's actually brighter behind it because the rest of the places the beam stops. Here the beam just accelerates and goes right through it, falsifying, creating an artifact of brightness behind it. Posterior shadowing because of reflective surface, and through transmission because of cystic composition. And then the last one is isoechoic. It's really difficult. It has a signature acoustic impedance that is extremely similar to the surrounding soft tissue. It's difficult to tell apart from it. Those are the most difficult to diagnose many times. So let's do a little bit of testing. How would you describe these lesions? Are they cystic lesions in the liver, or are they solid lesions in the liver in figure A and figure B? And I want you to take 5, 4, 3, 2, and 1. And if you said that they're both cysts, that the one on the left is a simple cyst, I completely agree with you. And if you said the right is a cyst, but it's a complex cyst, I also completely agree with you. Let's look at them. When you diagnose simple cysts or simple fluid containing structures or ascites, you will see that the actual fluid is anechoic. No echoes inside, lack of internal echoes, that they have a very nicely defined, well-defined posterior wall because there is no beam impedance at all. And then because of that, you have this through transmission artifact or posterior acoustic enhancement. So this is a simple liver cyst. Where else can you see this? You can see it in the normal and abnormal setting. This is a normal sagittal view of the gallbladder. You can see it's nicely distended. It's fluid-filled or bile-filled, and again, anechoic, nicely defined posterior wall and through transmission. So it is a simple cystic structure. Urinary bladder is another example, a filled urinary bladder. Here you see a pathologic view, a sagittal view through the right upper abdomen in the midline axillary line. You can see the liver and the kidney, and this patient has been in a trauma, and there's ascites or free fluid throughout the peritoneal cavity from visceral injury. So this patient has ascites, and one has a gallbladder that's filled with bile. Again, simple cystic structures. When we look at that complex cystic, the complex part either comes from blood, pus, debris, or sometimes even tumor can do this. So this is a complex cystic mass that has gone hemorrhagic transformation. You can see internal echoes, some retractile clot with a little bit of septa that are forming within it, some clumped up nodular sort of clots that are forming in it. The wall is there. It's ultimately a cystic lesion when it started, but perhaps the patient had trauma to this cyst or something like that. Somehow it hemorrhaged, or it's got infection or pus in it. Again, the posterior wall is nicely seen, but it's very, very it's not as sharp as the prior one, so it's hazy. But you still have that through transmission because at the end of the day, it's a relatively simple cyst. Here are a couple of other examples. This is a liver abscess that we see multiple sort of echogenic nodules and irregularity of the wall along its side. You can see internal echoes. It is hypoechoic. It's not really anechoic anymore. And then you see a patient with a right ovarian hemorrhagic cyst where this was a simple dominant follicle cyst that hemorrhaged, and you can see a meniscus level from the layering hemorrhage. This shows that there's no color flow within that hemorrhagic cyst, and so we can exclude a complex cystic mass, for example. So again, 2 examples of more complex cystic lesions. Well, now we've covered cysts. What about this? What do you think these lesions are? We have 3 images to the left, multiple hyperechoic nodules scattered throughout the liver. We have a single hypoechoic lesion, markedly hypoechoic, in the center of the liver, and then an isoechoic to the liver lesion that will be sort of difficult to diagnose to an untrained eye, right? And so what do you think these are? How would you describe them? We've already talked about the syntax. Of course, you're going to say, hey, these are hyperechoic lesions. This is a hypoechoic mass, and these are isoechoic. This is isoechoic lesion, and you would be correct. When we look at solid lesions, just like cysts, they tend to be most of the time well-defined. They can be infiltrative depending upon their nature, but they're relatively well-defined. They don't have the posterior acoustic enhancement. In fact, you'll see a little bit of shadowing here and a little bit of shadowing from sound attenuation. So you will not have that posterior acoustic enhancement typically, unless it's a cystic lesion, right? Solid lesions won't have it. And again, this is an example of a patient with metastatic melanoma with multiple hyperechoic metastasis. This is a patient with HCC, hepatocellular carcinoma, and a cirrhotic patient that is hypoechoic. And this is a young woman who has a benign focal nodular hyperplasia that is really just hiding itself in the normal liver parenchyma. It is isoechoic to the liver. What about calcium, bone, and metal? Interesting. These are substances, as you can recognize, that have a high acoustic impedance. They're strong reflectors. You will not be able to penetrate bone, calcium, or metal with sound. Therefore, you'll see that anterior margin as the sound enters that interface. You'll see an echogenic linear area, but you will see a lot of signal loss or posterior acoustic shadowing. So this is an example of a gallstone in a gallbladder. You can actually see the anterior margin of the gallbladder, or gallstone rather, but you will not see anything posteriorly to it. There could be anything here, and we do not have information on that. In the same way, this is a sagittal view through the aorta, and you're actually looking at ribs. These are ribs in the thoracolumbar spine, and these curvilinears are anterior parts of the vertebral body, but you'll see a lot of signal loss or acoustic shadowing posterior to that. So again, calcium, metal, bone, high AI or acoustic impedance, you'll get the curved surface and posterior acoustic shadowing. What about gas and air? How are they as reflective or refractive properties? They have very high refractive properties. No sound waves goes and comes out straight when it interacts with air, and therefore there's limited transmission. This is a view of the lung, so you actually are looking at a consolidated lung, and you can see the anterior margin of the pleura, but or the rib rather, it's a curvilinear surface, and you have that darkening because you have a pneumothorax here. So this is a pneumothorax with dark. You have air that's trapped in the pleural space. These are not anechoic, like super dark. They tend to be what's called dirty shadowing when they're large like that. Again, pneumothorax or free air in the abdomen, they're going to give you these posterior bands of dirty shadowing. This is an example of pneumobilia, gas in the biliary tree of the liver in a patient who had a hepaticojejunostomy and a Whipple procedure for pancreatic cancer. And you can see that they tend to be linear echogenic foci corresponding to air, but because they don't allow sound transmission, you're going to get a little bit of that dirty shadowing behind a bunch of them. So again, small foci of air with small posterior dirty shadowing. That structures kind of change with patient positioning. They correspond to air. So remember, they can have that in the lung or in the liver, in the abdomen. So let's just quickly review. We've talked about various artifacts. Here's an artifact of posterior shadowing caused by a substance or a stone with high acoustic impedance in a patient with gallbladder stones. Here's a patient with a simple liver cyst that lets all the sound through, and you get the posterior acoustic enhancement, sort of a benign entity. And then you have somewhere in between where you have a strong reflective surface like air, and then you have dirty shadowing behind it. This is a patient with pneumobilia or air in the biliary tree. So that's a good review. The last part on this I want to touch on is Doppler imaging. It's a little bit beyond the confines of this course, but I would like to here, because you're going to use Doppler ultrasound to detect Doppler shifts. Doppler is used to detect and characterize blood flow in vessels. I'll give you an example. Let's say, let me explain Doppler shift. Let's say we have two people. You have a young lady and a gentleman, and there's a police car with the siren on that's going from her to him. So as that police car moves towards the boy or the man, the sound waves of that siren take a shorter amount of time to reach his ear and take a longer amount of time to reach her ear. He experiences an area called higher frequency. The sound he hears is of a higher frequency. The sound she hears is a lower frequency with respect to the same sound that is generated by the siren. This is called change in frequency or frequency shift or Doppler shift. And this is the principle of Doppler that is used to assess patency and assess velocity of blood flow in vessels. Here's an example of a color Doppler of the common carotid artery and internal jugular vein that allows us to detect presence of flow and direction of flow. Due to Doppler shift, there's a positive frequency or Doppler shift in the common carotid artery, meaning there's blood flow towards the transducer that we've given it a red color. It could be purple or yellow if you wish, but we've given it a red color. The transducer is sitting here. This is having blood flow away from the transducer. It's going back to the heart, and so therefore we've designated as blue. Again, we're using frequency or Doppler shift to designate various colors to the flow of that substance, in this case, in the common carotid artery in the jugular vein in the neck. So these colors, again, can be arbitrarily aligned and changed, but you will use this to detect and quantitate flow. The other part of Doppler is called spectral Doppler. This is more of a graphical, not just a visual, but a graphical quantitative representation of the flow velocities. Again, in the common carotid artery, we have the flow here. We know that. We know it's going towards the heart. We turn on these Doppler gate to look at spectral Doppler, and we see this waveform. Notice that the waveform is a high-resistant pulsatile waveform that has a sharp systolic upstrike, a continuous diastolic flow, and the velocity in the range of 50 to 120 centimeters per second. This is very common. This is the typical waveform of common carotid artery. When you look at internal jugular vein, the flow is a little bit more monophasic, non-pulsatile. Yeah, there are some phasic differences due to respiratory variation and cardiac influence, but generally speaking, it doesn't have that sharp systolic upstroke. So again, internal jugular vein using spectral Doppler demonstrating that low-grade continuous flow, whereas we have this high-resistant pulsatile flow in the high-resistance vessels in the head and neck. So spectral and color Doppler is something that I want you to practice. All right, well, we're towards the end. I want to take the last 5 to 7 minutes to review some of the principles that we've learned utilizing clinical vignettes. Let's develop a systemic approach. Let's review some of the knowledge, how to select the probe positioning, scan planes, protocols, etc. And the other we will cover during the workshop that would follow this talk. Clinical vignette number 1, 47-year-old male with alcoholic cirrhosis and abdominal distension who is admitted to the emergency room with complaints of increased abdominal pain and distension and shortness of breath that has been worsening for about a month. Patient reports that, hey, this has happened in the past. It resolves when the, quote, water is taken away from her stomach. Your provisional diagnosis is consistent with large volume ascites in a cirrhotic patient with liver decompensation, and you feel that this ascites is something that requires draining because patient is short of breath. So what might you evaluate as the ultrasound person to evaluate this person's abdomen? Would you use a linear probe with high frequency phase area probe, small head, or would you use a curved probe for deeper penetration? So 5, 4, 3, 2, and 1. And if you said we're going to use for abdominal examination curved probe, you're completely right on. We're going to need that wider field of view, deeper penetration to check the contents of the abdominal cavity and to check the ascites. All right, very good. After selecting the curvilinear probe, your colleague begins to prep the patient and ask you what echogenicity you would expect the patient's simple ascites to be. A or 1 hyperechoic, 2 hypoechoic, 3 isoechoic, or 4 anechoic, and 5, 4, 3, 2, and 1. And if you said yes, it's simple ascites, it's going to be anechoic, you are absolutely on. This is a scan from a similar patient with a cirrhotic nodular liver with portal hypertension. You can see ascites superficial or in front of the anterior to the liver. Unfortunately, your colleague obtains the following image and asks, hey, what can I do to optimize this image? I'm not seeing what I should be seeing. All right, so you have a sort of a grayed out image. You maybe see some of the ascites here, but boy, it's just a lot of gray here. You can see the aorta, some of the bowel. You just don't have a good definition. Would you adjust the depth? Would you adjust the gain and the focal zone? Would you adjust the TGC? Would you use more gel? Or would you just say, oh, heck, just put a needle in it already? and let's get out of here. And if you said I would, use more gel because you have better contact. You don't really have areas of breakthrough. You have nice scan, but using more gel usually helps, I think, in my experience. And then adjusting, positioning the patient, adjusting that gain and that focal zone where you want the sharpest area, you're going to get a nice image like this. So I would adjust the gain and the focal zone and use more gel in that case. All right, finishing up provisionally, spontaneous bacterial peritonitis diagnosed. The patient is now being prepped for ultrasound-guided paracentesis, just to make sure. On witnessing the procedure, you observe the tenting of the peritoneal lining, this asterisk. Here's your needle coming in. You see this tenting, but you don't see the needle tip and you don't see the underlying bowel. You do see the ascites. What should you do? Should you just increase the depth, increase the gain, decrease the gain, or change the focal zone so you can make a safe paracentesis? And 5, 4, 3, 2, and 1. And if you said, you know what, I'm going to increase the depth, I definitely need to see that I don't injure the underlying bowel. You're absolutely correct. You must be able to see not only the needle tip nicely, you have to be able to see where you're actually inserting that needle and where it's going to end up away from the bowel loops. Absolutely true on this one. All right, the second vignette, 42-year-old female presenting the PCP for neck bulge. She's reports that she's felt a mass in the left side of her neck and she reports no other symptoms. You indeed do palpate a neck nodule. A TSH T3 and T4 are normal. And what is the most appropriate first test imaging? And I think we have the answer already. A thyroid ultrasound. It's an ultrasound course. Where would I find this information? You would find it on the ACR website. The American College of Radiology has very specific indications for what clinical query you should use, what modality. I mean, I know we have CT, MRI, PET scan, nuclear medicine, ultrasound, all these modalities, but the acr.org website allows you to give this ACR appropriate criteria, and it actually says here for palpable neck mass, ultrasound of the thyroid, 0 radiation, it's the way to go, usually, most of the time. And so for that thyroid ultrasound, what sort of probe would you use? Would you use the 9 megahertz, a 4 megahertz, or the 2 to 5 megahertz? And if you said linear probe, I need that nice superficial structure, not as deep penetration, it's a superficial structure, but I need a nice uniform beam so I can evaluate the small thyroid gland. You are absolutely correct. It's useful for all smart parts, procedure, for testes, for thyroid, for vascular evaluation, and sometimes even for soft tissue aspiration, use that linear transducer. All right, so we are now asked to label. Here's an image obtained at the same time, scanning of the thyroid. This is a transverse image. I want you to understand which one is the patient's right lobe and left lobe first. So is B the right lobe and D the left lobe, or is it reverse? And I want you to take a minute. We've talked about mirror. What is your left is to the patient's right. What is your right is the patient's left. And if you said absolutely B is the patient's right and D is the patient's left, you're correct. Let me orient you again. You're scanning head to toes to head. So the part that's nearest to the transducer is this part. This is the patient's neck. The back part of the neck would be down here. This is the posterior part. This is the patient's right to our left, and then this is the patient's left to our right. All right, so you've identified that. How can you confirm that A is the carotid artery and not the jugular vein? And I want you to think about it. We've just discussed some Doppler principles. It's only by using Doppler and looking at that waveform that you're going to be sure. So you look for a pulsatile structure, right? You look for that high resistance waveform, non-compressibility, and you can be on your way that that's a common carotid artery, not the jugular vein. The last question, the yellow arrow points to the trachea. And for what reason do we see that blackening? What is that artifact called? Why do we see it? And if you said the answer is due to that being air, and air being a very high reflector and not allowing beam penetration, you're absolutely correct. That is posterior acoustic shadowing due to air in the trachea. All right, well, you do this exam of the thyroid and you see a lesion. You see that the lesion is partly anechoic, but it has a couple of septa and you have some debris inside of this. Would you call this a simple cyst, a complex cyst, or a solid mass? Excellent. Okay, so if you said this is a complex cyst, you're absolutely right. A simple cyst should be anechoic, well-defined posterior wall, which we don't really have here. You have some grunge that's dependent. You don't see the wall in entirety, but you do have through transmission. So you have the posterior acoustic enhancement, but has some things in it. This is a complex cystic lesion, subsequently followed and was felt to be benign. The last of our vignettes is a 47-year-old female, post-operative day 3 after a ventral hernia wall repair with right upper quadrant pain that started 3 hours ago. She is rating it at 7 out of 10. She said she was just watching TV, having supper, and the pain began immediately thereafter. She has diabetes and appears distressed and tachycardic and febrile. So the question is, what is your differential diagnosis on this patient, and how would you initially evaluate it? Where are we going to go? We're going to go to the ACR.org website, and we're going to find that in a patient who, in this setting, where you suspect biliary disease or acute cholecystitis, we're going to start with the right upper quadrant ultrasound that is most appropriate. If the pain is not localized, vague, abdomen, pelvis, I can see going to abdomen, pelvis, but why use the radiation, right? Let's begin with an ultrasound in this patient. What patient position are we going to ideally use for assess the gallbladder? And what transducer are we going to use, right? So this patient doesn't have any bandages on. Sometimes patient with bandages, you have to change position. So think about it. What position are you going to put them? Where's the gallbladder? And if you see it or don't see it, what maneuver will you use? And then what is the best types of transducer to look at? Again, deeper structures in the abdomen. If you said that you're going to use the left lateral decubitus and supine, you're absolutely right. There are 2 right answers here. Patients, when you don't see the gallbladder, sometimes you can flip it out of the gallbladder fossa by putting them into a decubitus position. Remember that as you practice. And what is the best transducer? Again, intra-abdominal transducer. You're going to go with the low frequency curved transducer that gives you the best depth and bandwidth of view. You start tilting and fanning your probe along the long axis in an oblique fashion in the superior-inferior movement, as shown up here in the right upper quadrant, looking for gallstones. What will gallstones look like on ultrasound? Will they be hyperechoic structures with shadowing? Will they be hypoechoic structures with flow at the periphery? Will they be blue-colored lesions on Doppler imaging with color flow in them? Will they be anechoic cystic lesions inside a shrunken gallbladder? And 5, 4, 3, 2, and 1. And you're absolutely right. They will be hyperechoic stones that will be mobile on scanning. If you change patient position from supine to left lateral decubitus, you can actually see adjacent sludge that has built up adjacent to the gallstones, but there are multiple rounded hyperechoic gallstones with posterior shadowing due to pure beam penetration. So that is it. That brings us to the end of our talk. My name is Dr. Shah. I'm happy to entertain any questions, and thank you in the meantime for your kind attention.